Good afternoon. I'd like to welcome you to today's Medical Center Hour. I'm Marcia Gay-Childress from the Center for Biomedical Ethics and Humanities, and we've been bringing you these Medical Center Hour programs all this academic year. This is our closing program for the academic season. Our Medical Center Hour today is entitled When Germs Travel, Social, Economic, Political, and Cultural Aspects of Contagious Crises Across Time. We'll explore today the continuing challenges of contagious disease to public health and social order through some comparative discussion of major pandemics across the centuries, starting with the Black Death in the Middle Ages and up to the specter of pandemic influenza in our own time. In what ways are we all at risk when germs travel? How can the lessons of history inform contemporary public health policy and pandemic preparedness planning? We're delighted to have with us Dr. Howard Markel, physician historian and author of the acclaimed book, When Germs Travel. The UVA bookstore is here, by the way, with copies of When Germs Travel right outside the auditorium, and Dr. Markel has graciously agreed to sign copies following the program. Dr. Markel is visiting UVA from the University of Michigan in Ann Arbor. He's here as the 13th annual Kenneth R. Crispell Memorial History Lecturer. In the Medical Center Hour's partnership with the History of the Health Sciences Lecture Series, the Crispell Lecture is the highlight of that series, a program established and endowed in memory of former Dean of Medicine and Vice President Kenneth R. Crispell. A word here about Dr. Crispell, whom many in our audience knew prior to his death in 1996 at age 79. Ken Crispell was an endocrinologist who joined the UVA medical faculty in 1948. He was Dean of the Medical School from 1964 to 1971, at which time he was named the university's Vice President for Health Affairs. Under his leadership, the university's health sector, the physical buildings, the faculty, and many programs grew exponentially and gained greater national visibility. Dr. Crispell also founded UVA's Law and Medicine program and served for 10 years as University Professor of Law and Medicine. He was especially interested in the illness of public figures being made public. He co-authored the book Hidden Illness in the White House, and his interest in presidential illness made him a logical choice for serving on the Miller Center Commission on Presidential Disability and the 25th Amendment of the U.S. Constitution, which provides for transitions in instances of presidential disability and inability. And we'd also like to welcome today Marge Crispell, Dr. Crispell's widow, who's here, and with a contingent of others who certainly all knew Ken Crispell well. Welcome to all of you. It's altogether fitting that our Crispell lecturer today, Dr. Markel, comes from the University of Michigan and is himself an alumnus of the U of M. For Dr. Crispell was also a Michigan medical graduate, and his family has continued to have connections in Michigan and even in Ann Arbor. You'll find a short biography of Dr. Markel in your handout. He is the George E. Wantz M.D. Distinguished Professor of the History of Medicine, Professor of Pediatrics and Communicable Diseases, and Director for the Center of History of Medicine at the University of Michigan. Our program today is graciously co-presented with the History of the Health Sciences Lecture Series and the Institute for Practical Ethics and Public Life here at UVA. And we welcome Dr. Markel, and there'll be time at the close of his discussion for your questions and comments. We look forward to this presentation.
Well, thank you. Is the mic on? I'm always challenged by technology, and I find myself surrounded by it. So I'm deeply honored to be giving the Crispell lecture. It's quite an honor. I didn't know Dr. Crispell, but he sounds like a remarkable man. And I'm just delighted to be here at the University of Virginia. It's my first time here. I can see why so many people love it. It's just wonderful. Harry, can't hear?
Can you tap on your mic for me?
Okay. Anyway, I'm delighted to be here. Today I'm going to be talking about when germs travel, about the global marketplace that we live in, that is largely shaped and framed by organisms that we don't like to think about, and we certainly don't want a lot of contact with, but nevertheless they exist, and appear to be coming back with a vengeance if you have looked across the last 20 years or so. When historians look at epidemics, they try to come up with models. And they try to come up with structures of how to describe them. The first model I just want to briefly touch on is called the Epidemic as a 4-act play model. It's very nicely articulated in Charles Rosenberg's wonderful book, Explaining Epidemics. That's only actually one essay in that wonderful book. Dr. Rosenberg, if you don't know, is probably the preeminent historian of medicine in the world today. And there's very little you can't learn about the history of medicine from reading his book. He's a wonderful scholar. But he really based this model on a novel. And the novel, of course, is Albert Camus' The Plague. I teach The Plague every year in my literature and medicine course, and I'm deeply jealous of Albert Camus. He wasn't a doctor. He didn't do a residency program. He didn't get a Ph.D. And yet his description of an epidemic and how people behave in that crisis is perfect. You would be very hard-pressed to find a better source to start thinking about epidemics. It has perhaps one of the most gruesome openings in all of literature, an act that Dr. Rosenberg calls progressive revelation, but the paragraph begins, when leaving his surgery on the morning of April 16th, Dr. Bernard Rieu felt something soft under his foot. It was a dead rat, lying in the middle of the landing. On the spur of the moment, he kicked it to one side, and without giving it further thought, continued on his way downstairs. Only when he was stepping out onto the street did it occur to him that a dead rat had no business to be on his landing, and he turned back to ask the concierge of the building to see to its removal. It was not until he noticed old Monsieur Michel's reaction to the news that he realized the particular nature of his discovery. So in this first act of any epidemic, you are noticing something. Somebody is noticing something that is amiss, something that doesn't belong in the natural order of things. Act 2 is something that Rosenberg calls managing randomness. This is a Bruegel painting, Bruegel, the Elder Triumph of Death, during a bubonic plague epidemic. And as you can see, it's really quite chaotic. How do you manage this random event that comes out of the blue into your neck of the woods at that particular moment? And of course, it really depends on how you understand a great many things at that time. If you read Thucydides, the Peloponnesian War, you'll notice it's a great description of the wars that were going on. But there was a crisis going on very early in the war in terms of a plague epidemic. And that had a huge factor in how those battles ensued. Another act, the third act, is not just dealing with the random event, but managing the public response. Because the public wants you not to just stand there, but to do something. Sometimes you do things that are right, sometimes you do things that are wrong, sometimes it's in between. This is a cartoon from Puck magazine in 1884. It's New York Harbor. Instead of the regular battery, it's the disinfectant battery. And you see all these cannons, they're different disinfectants, carbolic acid, chloride of lime, and what have you. There is the kind of assisted immigrant we cannot afford to admit. Here's the Board of Health, by the way. And this is cholera. And he's dressed with a Turkish fez, wearing these rags, because people felt that cholera came from the Middle East, subcontinent, and Eastern Europe. And these were the types of immigrants that Americans did not want to welcome to its doors. The immigrant, by the way, and we could talk about this at length during the question and answer period, is a classic scapegoat to be blamed for the importation of infectious diseases. Sometimes, by the way, infectious diseases sprout up on native soil, so you can't really use that rubric all that well. That said, these people have often been blamed across time for the spread of epidemic disease. The most troubling act, Act 4, is subsidence and retrospection, or what I call the profound amnesia following the crisis. This is T.S. Eliot, who in his poem The Hollow Man wrote, "This is the way the world ends, not with a bang, but with a whimper." Let me give you an example. When SARS was all the rage, I was saying earlier, it was great business for, if you're a historian of quarantine, SARS was great. Generally, I'm like the Maytag repairman. People are not calling me, but when some type of epidemic is brewing, I get called. And I was on the McNeil-Lehrer hour, and Mr. Lehrer asked, well, what do you think the future of the SARS epidemic will be? I said, well, I can't predict with certainty, but I suspect within 12 to 15 weeks this will be over. The cases will resolve. And I will call you and say, hey, Mr. Lehrer, can I get on the air and we can do a wrap-up about SARS, and you won't come to the phone? He said, no, I'm much more polite than that, but let's see. Well, 12 weeks came by. SARS had subsided. I made my dutiful call to PBS, and I couldn't get through. And I'm not saying that to put a slam on Mr. Lehrer or any newsman. The point is that we go on. We don't think about it. Some of us do. Some of us who are in the business think about it. But most of human society thinks about it, as it's going on, it's a crisis, and then they forget about it. And that's truly problematic, because there's so much we can learn from these past events, and there's so much preparation we need to do for the events that may come in the future. Well, that's a very good narrative structure for an epidemic, but it's not that reliable. Not all epidemics follow that 4-act model precisely. So when I was thinking about this and writing these two books, Quarantine with Germs Travel, and I'm delighted they're selling copies up there. There's a warehouse in Baltimore with thousands of copies of that book. Both of my books. But I came up with something that I call the Leit Motiv model of epidemics and pandemics. Think of it as a giant cake mix. Now, sometimes you're making a devil's food cake. That's different than an angel's food cake or a strawberry shortcake. But you're using several ingredients that are in common. And you might use some of the ingredients for one type of cake, but others for another. But you know pretty much the usual suspects you're going to need for that endeavor. And here are some of them. The first is that epidemics are almost always framed and shaped, sometimes advanced, and sometimes hindered by how a given society understands a particular microbe to travel and infect others. This is a plague doctor in 1656. He's wearing that classic plague mask. There's no knowledge of germ theory or of rats or lice or things like that as a causational spread of the disease. Yet that's how they understood it, as something that came as God's punishment to a particular society. It may have come from the pollution of the atmosphere or rotting organic material, and hence your methods of correcting that situation would be geared towards how you understand it. Similarly, if you were in the biblical era, if you're reading Leviticus, 5 books of Moses, I love Leviticus. Whenever I'm at a bar mitzvah, I always turn to that because I get some work done while I'm praying. But if you want to read about infectious diseases, it's a wonderful section. And they talk a lot about leprosy and the disposal of excreta and the sounding of a shofar, for example, the ram's horn, which is done during the high holidays, was also used to warn different villages down the road that an epidemic had broken out. But if you were living in that era, you would definitely think that that epidemic was caused by God's will, that the community had done something wrong, and one way you would try to ameliorate that would be to pray or to become much more religious in your beliefs than you were previously, and hope to change your behavior. If you read Hippocrates, one of his great books, many books, is Epidemics. That, by the way, is where the phrase "first do no harm" comes from. It's not in the Hippocratic Oath. But his understanding of epidemics in ancient Greece were very different as well. So we could go through many different instances of history, particularly before the germ theory, where different societies, different countries, different groups of people had very different frameworks to explain an epidemic. And then when they tried to manage that randomness, when they tried to manage the public response, use those understandings as a tool. This, by the way, is the quarantine station at Hoffman Island in New York Harbor, and they thought that all, this is from 1892 from Harper's Weekly, they thought that all infectious diseases, particularly cholera, was imported by Russian Jews, and so they erected this large fence to keep those people on the other side. Another leitmotif is that the economic devastation typically associated with epidemics can have a strong influence on the public's response to a contagious crisis. This is hardly new. You can find this in the Middle Ages with plague epidemics, and you can find it all the way to the present. This just shows you the New York Stock Exchange during the SARS crisis, and from that august publication, the New York Post, all the news that's not fit to print, $30 billion. That was just one estimate. By the way, they don't want to read the New York Post down here. It's an incredible newspaper. I love it. It's about a quarter. And you can read it on the subway, and you can make it last as long as your subway ride. And you could read 12 other newspapers that day, and none of them have the same story as the New York Post. It's really a very interesting newspaper. But anyway, it probably costs a bit more than $30 billion. It probably costs, SARS crisis probably cost $60 billion to the world economy. We're suggesting if there was a 1918-like or a worse pandemic, it would cost probably $600 billion to the United States economy alone. So these are very expensive things, and people don't want to shut things down just because there's a threat of an epidemic, because if you shut things down, you lose commerce, you lose money, and that costs a lot. And again, it's not new. Emperor Justinian was author of the first sanitary law, international sanitary laws, and restricted trade in and out of his empire during plague epidemics. And so it's something that has been thought about for a long time. One of the most dangerous themes of epidemics past and present is the concealment of the problem from the world at large. This is China during the SARS pandemic. Now, if you recall that epidemic, not pandemic, if you recall SARS, the first cases actually occurred in Guangdong province of China in November. But they did not announce that there was a SARS death until April 30th, 2004. That's a very long period of time. And actually, the Hong Kong cases were reported earlier, even though they probably came from traffic from the Guangdong province at the Hotel Metropole in Hong Kong. So delaying, in this case, because of national or political issues, sometimes because of economic issues, really puts us all behind the 8 ball, because germs travel. And if you let people travel, the germs travel, the disease spreads, and the problem becomes much worse. As I said, it's hardly new. This is from Harper's Magazine of 1885. These are cholera roots during the 5th and 6th pandemics of cholera during the 19th century, showing you where they travel and so on. But concealment was a big issue during those pandemics as well. Whenever I'm talking to government officials about flu pandemics, I'm always telling them, read about cholera. Not only because it's interesting, but cholera really is the great pandemic disease of the 19th century. And a lot of the issues that we're dealing with today in terms of international health regulations and international trade and commerce really began with those international crises. These, to show you concealment, there was a terrible cholera epidemic in Hamburg, Germany. Hamburg was the largest port in the world. The second largest was New York City. It had an enormous amount of goods going out of there every day, and an enormous amount of immigrants who were leaving Eastern and Central Europe, mostly for American shores. Now, all those immigrants, before they boarded ships, were required to stay in various boarding houses until they could pass certain tests based on need and health before they got onto a ship bound for America. But frequently, they got sick either because they were already sick and the germ was incubating in them when they arrived in Hamburg, or they got sick because of these rather disgusting, not terribly nice living arrangement while they were waiting to ship off. And of course, cholera did strike in Hamburg. Here's the sick bay, and here are some, again, results of that. But Hamburg suppressed information that they had a raging epidemic in 1892 for about 3 to 4 weeks, and was still sending ships off, not just to the United States, but to other ports around the world. And probably that concealment helped worsen the epidemic. Why did they conceal it? Well, they didn't want to lose the money. It was an enormous financial issue to close the largest port in the world. And this is something that comes up again and again and again. It would be airports instead of seaports today. But it's something that really troubles a great many of us who are involved in pandemic preparedness. A nice segue to this, another leitmotif, is that the movement of people and other living beings and the speed of travel are essential factors in the spread of pandemic disease. So here you see a ship, the SS Kaiser Wilhelm, sailing into New York Harbor in 1910, and it took roughly 7 to 10 days for very late 1900s or the early very late 1800s, very early 1900s. It took about 14 to 21 days for TransPacific Travel. Well, if somebody has cholera, the incubation period for that is anywhere from 2 to 5 days. So they're likely to be sick, or visibly sick, long before they actually get to the port that they're arriving to. And you could potentially isolate them or treat them before they commingled with other people. Typhus was the biggest problem in the turn of the last century because it took about 21 days to incubate. And that was often longer than the travel time. And I talk about that in my book, Quarantine, where actually a whole boatload of Russian Jewish immigrants who had been exiled from one point of the Pale to another actually literally imported an epidemic of typhus into the Lower East Side of New York. And I'll leave you to read that book to find out what happened, but the short answer is bad stuff. And so the idea now, today, where you can travel from anywhere to anywhere else in less than 24 hours, really shrinks that time that helped public health officers of a century ago in terms of diagnosing and potentially mitigating the spread of an epidemic disease. Here, for example, are pathways of the Black Death, the bubonic plague, between 1347 and 1351. And you could see where it traveled during the various years, but probably coming from the Asian travel routes. But it took so long to get from one point to another that this was a several-year event as opposed to a several-day event. And we're talking about financial issues and travel speed. The birth of the quarantine, the Lazaretto at the Santa Maria de Nazareth Island in Venice, was founded in 1374, and that was largely in response to bubonic plague epidemics. Now, it's very interesting, some of it apocryphal, but quarantine comes from a word quarantenaria, which is 40-day law, or quarante giorno, 40 days. And that was considered the time that it was thought that a bubonic plague epidemic would burn itself out. And really, it's hard to say where that comes from. 40 days is a very popular number in biblical literature. It's also, if you look at the Hippocratic treatises of what is an acute or infectious disease versus what is a chronic disease, it's about 6 weeks, which is 42 days. So it's probably around that time. Other quarantines were 30 days, and it's been fine-tuned as we've known more and more about the spread, incubation, and natural history of diseases in the present. You know, if you were quarantining somebody for influenza today, that would be a couple of days versus, something like, as I say, typhus, which might be a little bit longer. The other things that came out of this rapid travel, as I was alluding to just a moment ago, were international sanitary conventions. And they began in 1851 and went all the way to the eve of World War II. They stopped for obvious reasons because of the Second World War. And they've since been picked up since the 70s and are very active and fertile places for discussion today. And when you read these annual reports of these international sanitary conventions, they're really marvelous documents because depending on the era, they have all different concepts of infectious disease or the spread of contagion, lots of heated debates by very famous people, Pasteur, Koch, whoever. But you also find the birth, if you will, of sanitary regulations, of inspections of people and goods when they go from one part of the world to another. So this is not a new idea. It's something we've been struggling with since at least the mid-19th century. For example, international immigration reception centers such as the famed Ellis Island were developed to inspect people to make sure they weren't sick when they got in. But when an immigrant had traveled to Ellis Island, they had already been physically examined at least 3 to 4 times before they ever got on a boat to come to America. Once when they left their province, once when they got onto a train, and then at the port they were leaving, such as Hamburg, they would be inspected once again. So each time you would cut down the level of infectious diseases because you didn't want infectious diseases traveling from one place to another. Another very important leitmotif that gets more important every day is that widespread media coverage of epidemics is not new, and it's an essential aspect of any epidemic. These are some various magazines from the 1890s during a cholera pandemic, and they were widely reported then. People always like to talk about the 1918 flu as the first world media epidemic. It really, the 1892 cholera epidemic was widely reported, as were other cholera epidemics that preceded it. The problem with the press is that it's not a monolithic organization. There's many different people who write for magazines or newspapers. There's different levels of newspapers and magazines. There's television stations, there's cable stations, there's opinion magazines, and now there's blogs. And so anybody in their pajamas and a keyboard can write about almost anything, and blogs sometimes have legs. So, there's just such a multiplicity of news outlets or information outlets, and judging what are the good news outlets or the reliable ones from the less reliable ones is really a challenge for a 21st century citizen. And it's made even more challenging. We were just talking earlier about the demise of many newspapers and news organizations. So that, for example, for many years I've written for the science section of the New York Times, and and that's the New York Times, probably the most profitable, or used to be the most profitable and well-staffed newspaper in the world. All their bureaus, not just science or health desk, but international desk and the Washington Bureau, have been cut extremely. And so if you have 20 people covering an event versus 3 people covering an event, things change quite a bit. And then if you have people yelling and bloviating on the air, that changes things too. Exactly what you don't want during a crisis. So how we handle the media. It's one thing just to rail at them and say, oh, the media is always bad. Well, it's not. Sometimes the media is quite helpful, quite accurate, and quite good. But how do we sift through this massive influx of information or disinformation is going to be one of the great challenges of pandemics in the future. Another troubling thing is that our fascination with the suddenly appearing microbe that kills relatively few in spectacular fashion often trumps our response to infectious scourges that patiently kill millions every year. So here you see, I love this anthrax, the truth about SARS, and the MMR vaccine, that was a big deal, bird flu. That's what you hear about. Yet 400 people died of tuberculosis in the last hour, and the next hour, and the hour after that. 300 people died of AIDS in the last hour, and the next hour, and the hour after that. 1,500 people die of some infectious disease around the world every hour. Hundreds of kids die of diarrhea every day, of something that's completely treatable. 400,000 kids die of measles every year. We've had a great vaccine that cost 24 cents available since 1962. So we don't think about the regular garden variety infectious diseases that cart off way too many people. We spend a lot more time thinking about anthrax and bird flu. And those are important to be sure. And it's not mutually exclusive, but we have to think about it, I think, in a more global way. A very sad theme in the history of epidemics, and I alluded to this, is the tendency to scapegoat or blame individuals or social groups for the importation of infection. This is a cartoon from Judge magazine in 1892, around the time of this cholera epidemic. And here they come arm in arm. Here you have Asiatic cholera with a German or Dutch immigrant and an East European Jewish immigrant, and Uncle Sam cowering behind here. So the idea that scapegoats, this group or that group, this so-called socially undesirable group, is the importer of an infectious disease, is a big theme, something that I've spent a lot of my career thinking about and frankly worrying about. We have not seen it, we did not see it that much in the 1918 flu epidemic. And my theory for that is that it was so widely spread and so ubiquitous that there wasn't time to blame one particular group. But we find it for so many epidemics in the past. These are the cholera epidemics that I was alluding to, but remember AIDS and the original victims of that. And we saw it with SARS. I was telling a story in the last hour about being, during the SARS epidemic, being in Boston airport, sitting next to a Korean family, and there were several rows of empty seats. No one wanted to sit next to this Asian family, even though they had not been anywhere near Asia for 6 or 7 months. They'd been traveling through America. And the father, who spoke wonderful English, said, "You want to see something really funny?" And I said, "Yeah." And he took out a face mask from his travel bag and put it on, and those 4 rows of empty seats became 12 rows of empty seats. And you may recall, too, that University of California at Berkeley, for about 2 minutes, closed their summer school to all Asian students until the response was so remarkably bad. So we're not, in our enlightened age, let's not think that we're free of scapegoating. And I worry about where, say, bird flu originates, how we will respond to that, and that is a problem. Here's a cartoon from SARS, epidemic, bad Chinese takeout. So there's always a lot of scapegoating going on. Well, let's go back to the future. The very famous, by the way, photograph of on the dock of Ellis Island. Plague, still a problem. This is the 1994 outbreak in India, but we still have about 10 to 12 cases in the southwest of the United States. We still see plague in other parts of the world as well. Ebola virus. I always love to assign to my freshmen the hot zone. There's one book I know they're going to read. Something about a guy's face melting off that really gets an 18-year-old to reading through pages. But of course, Ebola was a big issue, and if it had gotten more easily transmissible, it could have been very frightening indeed. The threat of bioterrorism, not just naturally occurring epidemic threats, but the idea that someone might send a letter laced with anthrax is something very troubling, as we were concerned in the aftermath of 2001, of 9/11, of smallpox somehow being used as a weapon, or bubonic plague, or things like that. And by the way, up until 2001, it was very easy to send away for culture specimens, and that's been very restricted of all these huge pathogens, and that's no longer the case. I've alluded to SARS. This is the Hong Kong airport during SARS. I don't know if you've ever been to the Hong Kong airport. It's rarely like that. This is the Toronto airport. And that was a huge crisis that a lot of people thought about. And yet, only about 800 people died of SARS, all tragedies, I understand. And only about 8,000 people contracted SARS. And yet, that's what we talked about all the time for about 2.5 months in 2003. And just 2 summers ago, the summer of Andrew Speaker, a young man with extremely drug-resistant tuberculosis. He claims he only had multiply drug-resistant, or moderately drug-resistant tuberculosis. And he wanted to get married and go on his honeymoon, and so he was advised very strongly not to travel by members of the Fulton County Health Department, the Georgia Public Health Department, and CDC officers. But they can't do anything until he actually traveled. And then when he traveled, it became a whole international crisis. Well, if you think of the transmission of TB, you need to be breathing and rebreathing air of somebody who is ill for 8 or more hours. That sounds like the average transatlantic flight to me. And that's not exactly the kind of guy you would want to be sitting next to with that entity. I actually wrote about Mr. Speaker for the Washington Post. They asked me to write a Sunday column. I called him Typhoid Mary with a law degree. His father called me. They're both personal injury attorneys. By the way, you know what the definition of a tragedy is? Is a busload of lawyers going off a cliff and one of the seats being empty. But personal injury lawyers. But anyway, this father called and was very upset with what I had said. I said, well, it's an opinion piece. That was just my opinion, honestly. So, the problem is that it really created a lot of problems in how we look at the traveling people and individual responsibilities towards the health of others. It's the classic line that I'm sure your mother told you when you were a kid: if you're sick, stay home. And yet, how do we inculcate that responsibility to everyone, that no one's above that? If you're sick, stay home, regardless of what you have planned in your life. Well, avian flu, is it really the biggest contagious threat that we face in the 21st century? Well, it might be, but I'm not as certain that it's going to be. I think we need to take it seriously, and I think we need to plan for it, and I think it's inevitable that we'll have some type of flu pandemic in the future. But as I said earlier, there are many other candidates for the next contagious crisis, and I think we need to think about all of them. I don't think it's mutually exclusive, whether you're thinking of bioterrorism or epidemics in general, if you're thinking of flu or you're thinking of cholera or plague or AIDS or TB. We need to think about all of them and come up with international, globalized surveillance plans and treatment plans for all of those problems. Why do I say that? Well, look at airport travel. As I said, you can travel anywhere to anywhere else in a matter of hours. I hope this works. This is just a cartoon or a daily international air traffic over 24 hours, but it's done in time-lapse photography, so it's 60 seconds. So this shows you all the traffic that's going on. You know, the United States is always lit up. I just love this. I play with it all the time. How much is that? We're really finding it entertaining. And you can see there's a European traffic going, from America. Probably early morning hours now. Everyone's landing there. And you can also see areas of the world that are not well trafficked. Southeast Asia certainly is, but parts of Africa are not. Parts of Australia are, but parts are not. What former USSR, such as Siberia, is not. So you have a lot of traffic, a lot of people traveling from one place to the other. Many of them could be ill and could take their diseases with them. We also have international transport of goods, food, insects, animal products. We really live in a just-in-time economy. We were talking about this in the last hour, that if you're a diabetic, your insulin may come from Indianapolis, Eli Lilly, but your needle might come from Pakistan, your syringe, and the alcohol penny swab might come from China. If one of those systems is broken, you need all three for your daily or your twice daily or whatever injections of insulin. There's so many aspects of our lives that we don't even think about that are connected to these international pathways. And of course, living beings can hop on board, as we saw with West Nile fever a few years back, or human beings, or animal products such as mad cow disease or things like that. So it's really a wonderful world in terms of goods and services, but it's also a very potentially dangerous world as well. And this doesn't even begin to count the problems that we suspect will be developing because of global warming, climate change, and evolving disease burdens. For example, as it gets hotter in certain areas, you might see more mosquito breeding. If you see more mosquito breeding in areas where there's a lot of malaria or dengue fever or things like that, you could see more cases of that. If you have less water, you could have all sorts of gastrointestinal diseases spreading, and so on and so forth. So how we interact with the climate and how the climate interacts with the microbial world, and then the microbial world interacts with us, is something that I think we're going to have to contend with in the years to come. Again, this is an op-ed I did for the Times, which actually turned out to be an op chart called the Epidemic Scoreboard. And you can see, in proportion, these are the things that kill us. TB is the biggest one, and malaria and AIDS. Tiny little box in the corner is SARS. This was during the SARS epidemic. But we don't think as much about TB or malaria or AIDS. AIDS used to be hot, but now it's not nearly as exciting or as it needs to be. Or diarrheal diseases, how many people that kills every day. So I think we need to think very globally, that when we silo all this, that it's just flu, or it's just bioterrorism, or it's just TB, or it's just AIDS, that we're missing the boat. We need to think really globally about the spread of these diseases and how they interact with all of us. Well, Time Magazine on November 7, 2005 was doing a special issue on pandemic preparedness. And I was actually in the National Archives in San Bruno, California branch, the San Francisco branch of the National Archives. And I got called by a reporter. And he kept asking me, well, when and what will be the next contagious crisis? And I hemmed and I hawed. And I said, well, you know, I'm a historian. I'm not really comfortable with the future. And he said, oh, come on, Doc, give me a prognosis. And I kept stalling, and finally I got frustrated because he kept badgering me. I finally said, look, no one really knows what's going to happen. Anyone who says they do is either an idiot or lying. And that's how I'm quoted. You have to be very careful what you say. On the other hand, you can't prove me wrong. We don't. But just because we don't know doesn't mean that we want to put our head that something will happen. Things have already happened. We have never really conquered infectious diseases, despite a slew of books that came out in the late 60s and the 70s and the early 80s to suggest otherwise. They are living beings. They have hopes, dreams, and aspirations. Maybe not the same as ours, but they want to infect and breed in others. And we have to think about that. And for every move we do to try to counter or circumvent them, these organisms come up with different moves to try and counter or circumvent what we're doing. We never really conquer them. We merely wrestle them to a draw. But that's a noble fight, and it's one that I think we should be fighting actively every day. And so what I'd like to leave you with is the concept is that not all is lost, because it's not. There's never been a better time in human history to have a pandemic than today, except for tomorrow. But when I say that, I mean it's never been a better time because there's so much we can do. And the rapidity with which we find out information is remarkable. You take SARS, for example. Within 8 days after the Hotel Metropole cases, they had already figured out that it was a coronavirus and the genome of that virus. That beat the world's record for discovering a new entity and actually genetically figuring out what it was, which was 2.5 years, and that was HIV. If you look at older ones, bubonic plague, it took hundreds of thousands of years to figure that out. The point I'm making is that science has advanced to a point where our methods are really quite good. And there's a lot that we can do. And there's a lot that we should be doing in terms of surveillance, prevention, getting people good food and water, because half the world doesn't have access to clean water on a daily basis, and improving the access of health care for all. And so that's what I'd like you to leave with, that it is a good time to be living, and that we need to have not a panic approach to these threats, but an informed concern. Be concerned about it, think about it, talk about it with your colleagues, and also talk about it with your congressmen and your duly elected representatives. Because it's when you don't think about these issues, when you blow them off, when you develop that profound amnesia, that these events bite us with the most ferocity. And so I'll close at that point and take any questions that you might have. Thank you very much.
Thank you so much. We have quite a bit of time for comments and questions from the audience, and I will come around with the mic so that you end up on tape. Any hands? A lot of information to absorb. Please identify yourself when you ask your question.
Hi, my name is Harmony Caton. I'm a fourth-year medical student here at UVA. And my question is sort of, how do you inspire people to be concerned about the non-snazzy diseases like malaria and measles? And how do you get an American populace to be concerned about something that isn't really going to affect us because, well, we have measles vaccine?
Mm-hmm. I think it's a very good question. It's something I spent a lot of my career trying to do. So coming here today is part of that. What I found is very useful is, as a historian, is to tell these stories in compelling and human ways with real people, and to try to get the reader or the audience to identify with that individual. And a lot of that, the book When Germs Travel does hopefully that. I think we really need to make people aware of what Jacob Riis once said, how the other half lives. Well, Jacob Riis was a great journalist in the 1890s who wrote a famous book about the Lower East Side called How the Other Half Lives, and it was based on a French maxim that half the world really doesn't know how the other half lives. So all of us sitting here in this beautiful medical center, not all of us, but many of us have no idea about the remarkable poverty of someone living in India or Africa or wherever. And we need to know about that. We need to go there. We need to see it. And then we need to take action against it. And we have to keep talking about it. And I think one thing that all of us do in the medical profession, whether we acknowledge it or not, is that we teach. You don't have to be a professor in a medical school for that obligation. You teach your patients. You teach your colleagues. You talk about things all the time. And I think this is one of the things that we need to do as both medical and public health professionals, is teach our fellow human beings about these threats on a daily basis. We're not doing enough of that. And I think, if I had to list the greatest health threats facing the world today, it'd be all those unsexy things you just charted.
Another question?
From Dick Pearson from Student Affairs and also from Infectious Diseases with some time overseas. I think it might be time to push nationally for inclusion in the medical school curriculum, sort of the global health disease burden, and that's been proposed, and it may be something that we could do through the Association of American Medical Colleges and the LCME, so that at least our medical students and hopefully nursing students and other healthcare providers hear about total disease burdens. One question I have for you, it's interesting that many of the epidemics occurred at a time when societal needs took precedence over individual desires.
Yeah.
In our particular society, we've sort of gone way to the other direction, which allows us to let someone with multi-drug resistant TB loose on a plane and only later in Europe, after exposing many people, sort of solve that problem. So one of the questions and issues is, how will we in our society respond when quarantine is necessary?
Well, that's a very good question. By the way, your point's well taken. Many medical schools are already doing this global health initiatives, and very different. We're about the same age, I suspect. From when
I think you're a little younger.
Okay. Well, whatever. There wasn't a lot of global health being taught back then. That's the tug of war of quarantine. The ancient Roman law of public health is that the health and needs of the many outweigh the needs of the individual. Very standard law or premise for law in most public health statutes that still exist in the law books in the United States to this day. So most cities or most states or most of the federal government have policies that they can quarantine people quite easily if they see the need. But what has changed in a all sorts of things, civil rights and the Watergate era and distrust of the government and Vietnam and so on and so forth, that at least in the American context, is that most Americans have a very different relationship with their government than they might have had 50 or 100 years ago. When I first started studying quarantine, it was really inspired by working with a lot of HIV patients who were asking me, perhaps might they be quarantined because they had HIV in the early 1980s. And I was struck by that question and the fact that these individuals had been stigmatized on so many levels that was not a bad question to ask. It was a reasonable question to ask. And yet, you do see this again and again in modern public health issues, is that what about the needs of the individual? And we haven't quite worked that out. I think if somebody is actually spreading a deadly disease, and we need to treat them with respect, with courtesy, we have to come up with ways that don't put them on quarantine islands like in the 1890s or Typhoid Mary in the early 1900s. We don't want cruel and inhumane punishment or inhumane punishment. But we also must realize that by virtue of isolating anybody, it's different. You're not in society if you have that label on you. Most people, if you look even in more recent crises, such as SARS, if they're told to stay home, they'll do that. How long is a critical issue because some people have to work, some are hourly workers, and so on and so forth. But it's the rare person who flouts all these rules and then travels widespread. Many public health people say we need to really try to understand their psychology and work with them, and I admire those people for doing that. But part of me wonders if you are truly identified with a deadly disease and you are wantonly spreading it around, do we need some type of stronger protection? And I guess the way I've asked that, I'm thinking we might. But having said that, I think that's the exception rather than the rule. But with a very contagious disease, you don't need that many exceptions to cause problems. So it's a real dilemma. And it's a real dilemma that's being discussed at the highest levels of the federal government in this country and at the WHO of this ancient tug of war of the needs of the many versus the needs of the individual. If I use history as my guide, the needs of the many almost always win out. So if you're using historical precedent, it almost always wins out.
Preston Reynolds.
How are you?
I'm good. How are you? Lovely talk. Right now we're seeing President Obama really embracing health reform as a critical component of economic reform. We're not going to get economic recovery until we really contain healthcare costs. We have the G20 today, or this, currently going
We got
on.
the protest first.
Protest first, right. What is it? Financial Foolish Day?
Yeah.
And we have a global recession.
Yeah.
And we have now 57 plus more million people thrown into poverty. But I don't hear globally a call for a global response to what you're suggesting is setting up a potential pandemic or increasing infectious diseases of the poor and the poverty.
Mm-hmm.
So I'm really asking you, is this an opportunity globally to create a different health response advocating within the medical profession like we're doing here in the United States?
Well, it is. I don't know if we'll seize that opportunity. What I worry about most is that there are so many crises on the plate right now that it might be very easy for the health crisis to be given short shrift, even though I thoroughly agree with you that a lot of our economic issues are intertwined with what used to be called mercantilism, that the health of the nation or state is very much involved with the economic health of the nation or state. What I've been reading lately is that several congressmen are worried that putting, just in the national context, a universal health scheme is just not the right time. But in my 48, nearly 49 years, I don't think I've ever seen the right time being articulated out of Washington. It's like, if not now, when? But I don't think a national scheme is enough. I think you're right. And particularly, I talk about this in my book, When Germs Travel, a lot, is that the idea of local or state or national protections for health, whether it's chronic or acute, are long since gone. It really is a very tiny global village. And the health of people, doing our computing needs wherever, does impact upon us here in Charlottesville and so on and so forth. And so I think these are things we need to think about. And how do we inspire other of these G20? Because it's going to be the rich countries that have to take the lead. I'm very hopeful that the current holder of the office of the president has that kind of charisma and vision to do that. But that is a remarkable task. But, as you know so well, ideas percolate slowly until they're sort of like a snowball going down a hill, and then they seem so obvious to us. And so the idea about global health, we were just talking, when we were in medical school, global health, what's that? And now all of my students are talking about that. So I'm not an optimistic guy, but I'm a lot more optimistic than I used to be about it. But I think it's above my pay grade to suggest how that's going to be done. I have no idea. That's it.
I'm Ed Russell, and I'm a historian. I have a great deal of sympathy for public health officials faced with a potential epidemic because it seems almost impossible to get it right.
Yeah.
Either they underreact and are criticized, or it isn't as bad as they thought it might be, and they're criticized for overreacting. So it's a tough position to be in. Have your studies of a few thousand years of responses to epidemics enabled you to pull out some elements that you might call the Leit Motiv of successful responses to epidemics?
Yeah, we have looked at that, particularly with our flu work that we've been doing for the federal government. I talked a little bit about that a couple hours ago. But you're absolutely right, hitting that sweet spot, is the baseball term. If you act too early, you close down the port, money is lost, and everyone says, what'd you do that for? You act too late, people die. What'd you do that for? So that's very tough to do. What we are finding in our study, we've been doing sorry if I'm repeating myself to people at the earlier talk. Our center for the history of medicine at the University of Michigan has been working with the CDC now for several years, looking at great depth at the 1918 pandemic at 50 major cities, all with populations of 100,000 to 5.2 million, looking at their healthcare or public health structure, their intra-agency organizational charts, of the compliance issues, of the population, is it poor, is it rich, is there immigrants, are there African Americans, ethnic groups, and so on, and trying to tease out what factors help. One thing that we know, we published this in JAMA in 2007, is that those cities in the 1918 pandemic that acted early, which makes obvious sense. You have to act, even if you're called acting too early, it's better probably to act early than late because the disease spreads. They use more than one of these types of measures, quarantine, isolation, school closure, public gathering, and kept them on line for a long period of time because these mitigation strategies don't prevent a disease, they just buy you time. What's going to help us in the future are either, if it's a bacterial infection, antibiotics if there's no resistance, antivirals if there's no resistance, and vaccine if we can get enough produced and into people's arms. But what I have found in a lot of these city studies that we're still doing and constructing this giant encyclopedia of the flu epidemic is that cities that had very competent health officers that were well trusted and worked well with the mayor and the city council and the governor and so on, they had a much greater track record than those that were fighting. And there are quite a few instances where you had the mayor not talking to the health commissioner, not talking to the governor, et cetera, et cetera. Different communities that had a more homogeneous mix, it made their public education efforts a bit easier, but it wasn't insurmountable. And many large cities like New York and Chicago did a wonderful job in 1918, as well as in the 1892 cholera epidemic, of publicly informing immigrant groups using their languages and having not just translators, but representatives of their community. Now, this is not to say that the good old days were that great. There was still a lot of nativism and prejudice and so on. But there were efforts made. Multiculturalism was not invented in the late 20th century. So those types of things seem to have helped quite a bit. Economic situations matter a great deal. And when a state or a city or a country is broke, people act badly. And when economies are doing badly, people act out a bit. And so that really worries me now, coming from the state of Michigan. You know, if we would have talked 10 years ago about GM going bankrupt, I would have laughed you out of the room. You know, what's good for America, what's good for GM is good for America. What's good for the world is good for America. Anyway, that kind of situation is really quite troubling. So, having said all that, though, and this is not, I don't have a quantitative answer for you, but this is just as somebody who observes human nature for a while, is that I have more faith in human beings during a crisis than I think some of our leaders have articulated. I think people want to do the right thing if they're told in a reasonable manner what that right thing might be. I think people are smarter than we give them credit for being. And that part of our job, whether you're a historian or a physician or a public health person or a nurse, anyone in this broad category that's brought all of us into this room, it's our job, it's our responsibility, it's our moral responsibility to be out there and getting people not excited in a negative way, but concerned enough to want to do something about it and thinking about it all the time. Not too much, not like Woody Allen, but think about it.
I think we've come to the end of our hour, and with the end of this hour, the end of the Medical Center hour for this academic year, I'd like you to please join me in thanking Dr. Howard Markel for a very interesting Thank you. And please join us in the fall. We start programs again September the 16th. And we'll look forward to seeing you and talking with you through next year. Thank you so much.